Good afternoon. I'd like to thank Dr. Krishnuma Mansukhani for inviting me to talk on laryngeal EMG, though I must admit it's a slightly daunting task to be talking to neurophysiologists and neurologists. This talk goes much easier when I'm talking to ENT surgeons, but here goes common, not so uncommon, and bizarre in laryngeal electromyography. I'm a laryngologist working in Bombay Hospital since the past 14 years. And we are indeed blessed to have one of the world's best EMG departments, literally right across the corridor. As a laryngologist, neurophysiologist, neurologist, and a speech language pathologist are our very good friends. So laryngeal EMG, as many of us know, was first introduced in 1944 by Weddell. And we also know that laryngeal EMG evaluates the integrity of the laryngeal muscles and nerves. So what is the role of laryngeal EMG as far as laryngology is concerned? There are two principal indications of laryngeal EMG. One would be therapeutic uses, and the other would be diagnostic uses. Now, therapeutic uses are what we primarily are using laryngeal EMG for in Bombay Hospital. And the indications are almost 80 to 85% of the times in guiding the botulinum toxin into the targeted laryngeal muscle with the aid of the laryngeal EMG. Occasionally, we do inject botulinum toxin into the cricopharyngeal muscle also when that has gone into a spasm, and occasionally into the thyroarytenoid muscle in cases of contact granuloma when we are trying to create a vocal fold paresis. As far as the diagnostic uses of laryngeal EMG are concerned, one of the primary uses would be to assess the recurrent laryngeal nerve function, and also in terms of its prognosis, so that if we do repeated laryngeal EMGs of the thyroarytenoid muscle and we find that the patient is getting better potentials, then we know that we could wait longer and probably continue just speech language pathology rather than going for surgery. Occasionally, there may be a doubt as to whether there's a vocal fold paralysis as opposed to a fixation of the cricoarytenoid joint. And the laryngeal EMG is very useful over there because a good signal would suggest that there is a fixation rather than a paralysis. You can also assess the superior laryngeal nerve function because assessing the cricothyroid muscle is quite easy, as the cricothyroid muscle is very superficial in the neck. And even in the diagnosis of spasmodic dysphonia, myasthenia gravis, and even hysterical dysphonia. So various electrodes can be used as you know in EMG. Typically what we're using in laryngeal EMG in Bombay Hospital is the monopolar needle, where of course the entire needle has covered, is ensheathed except for the tip, which lies exposed. And there are advantages to using a hook wire electrode wherein basically the hook wire is present within a needle. So when you insert the needle and then you withdraw the needle, the hooked wire is like a barbed wire, which kind of gets caught into that exact muscle you want it to, and it won't get dislodged. So that's the advantage. It's very easy to take it out by pulling it out, but the disadvantage is that if it's not been correctly placed into the muscle of concern, then it cannot be relocated. I don't have any personal experience with the hook wire. We're typically using the monopolar needles. And the reason different needles have been created is because there are different zones of detection then. We get this circular zone of detection with the monopolar needle. With the concentric, it's like half moon. Bipolar is a very small zone of detection. And then you have single fiber electrodes also available. So this slide is more for me than you all to remember what is a motor unit potential, and the action potentials which belong to it are, of course, the motor unit action potentials. But what is important to remember is that depending on the muscle which is being tested on voluntary contraction, the instruction given to the patient changes. So if we are going to check for the voluntary contraction in a thyroarytenoid muscle, which is primarily responsible for the vocal folds to come together or adduction, then we ask the patient to say E or phonate. But if we are checking the posterior cricoarytenoid muscle, which is the only abductor of the vocal folds, then we will ask the patient to sniff so that the vocal folds pull apart. And if we're checking the cricothyroid muscle, then we'll ask the patient to go from low to high, because when the patient goes into a high pitch, that's when the cricothyroid muscle really gets activated. As far as the interpretation of the laryngeal EMG results are concerned, just like any other EMG, there is the insertional activity. And within the larynx, you would have, again, bursts of electrical activity lasting not more than several hundred milliseconds. The spontaneous activity, actually, in the vocal folds at rest, there should be no activity. However, it's been found that the laryngeal muscles are almost never at complete rest. So you'll always have a slight baseline activity. With minimal voluntary contraction, you're looking for the waveform morphology, which means the shape, amplitude, and the duration of the motor unit potentials. And typically in the vocal folds, one would have 1 to 2 motor unit potentials with a firing rate of 2 to 5 per second, lasting for about 5 to 6 milliseconds with 200 to 500 microvolt amplitude. And then with the maximum voluntary contraction, one is looking at the recruitment and looking for the full interference pattern. So this is the laryngeal EMG in one of our patients, where you see the baseline EMG, there is some activity. And on saying E, you get a typical full interference pattern, as you can see at the bottom part of the screen. So what happens in as far as diagnostic EMG is concerned, one would get certain specific abnormalities and specific diseases. So in low motor neuron diseases like ALS and polio and recurrent laryngeal nerve deinvasion, one would get an increased insertional activity, occasionally positive waves and even fibrillation potentials, prolonged motor unit potential, and an incomplete interference pattern. With basal ganglia disorders, and spasmodic dysphonia is considered to be a basal ganglia disorder, and most likely, one would get a prephonatory burst and also an increased activity with the voice spasms. So when you hear the voice spasm, you will also see the increased activity. With vocal tremors, rhythmic periodic discharges of the motor unit potentials have been described. With muscle disorders such as myositis and muscular dystrophy, one would get either an increased or a decreased insertional activity, positive sharp waves, fibrillation potentials, complex repetitive discharge, a short motor unit potential, and rapid recruitment. As far as the neuromuscular junction disorders are concerned, and myasthenia gravis is obviously one of the common ones we see, repetitive stimulation studies are abnormal. And with UMN disorders, I think there is very less or sparse literature, but basically the decreased recruitment is seen and a decreased interference pattern with a firing rate which is very slow of the motor unit action potentials. Once again, we don't do much of diagnostic laryngeal EMG other than assessing the function of the recurrent laryngeal or the superior laryngeal nerve, really. Let's talk about what we do a lot of. We use the EMG a lot for adductor spasmodic dysphonia. So what happens when we're checking the activity in the thyroarytenoid muscle, which is one of the primary adductors of the larynx. And it is the adductors which are going into spasm in adductor spasmodic dysphonia. So at rest, normally there should be no activity, but a patient with ADSD would have a baseline EMG activity present, which would be of a variable strength. And when the patient is asked to phonate, say E, as I mentioned, then a full interference pattern is going to be seen both in normal patients also and in ADSD patients also. But in ADSD, one would see a prephonatory burst. So when I tell a patient, say E, just the minute they think about saying E a split second before even saying it, one would see the burst. So that's called a prephonatory burst, and it's diagnostic. And I'm sure all of you know what spasmodic dysphonia is. But just for some juniors who may not know, it's basically a focal laryngeal primary dystonia that's causing a tightening of the various intralaryngeal muscles. So when the adductor group is involved, it's called adductor spasmodic dysphonia, and it is an action-induced laryngeal movement disorder. Only the volitional cortically driven system is affected. So when you laugh, cry, you're angry, typically the voice would be good. And so that's one of the ways of even diagnosing spasmodic dysphonia. And depending on which muscle is going into spasm, it could be adductor, which is seen in about 80 to 85% of the times. Or if it is the abductor group of muscles causing breathy spasms, which is seen in about 10 to 12% of the patients, and it's known as ABSD. A combination of the two is a mixed spasmodic dysphonia, and there are some researchers who feel that actually every SD has a combination element, but just a very strong preponderance of one type. And tremor can be present along with spasmodic dysphonia in almost 30% of the cases, and one can have an essential vocal tremor even without SD. And Meek syndrome is a situation where you'd have ADSD and you'll have a cervical dystonia or mandibular dystonia, pharyngeal dystonia, etc. So when we talk about ADSD, we typically ask the patient to say sentences which have vowels, because on vowels we see the spasms very clearly. Then we do ask the patient to whisper and sing. Typically that's when the spasms disappear. And I'm just going to play the voice of a patient of ADSD. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is actually a young actress. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Singing. 1, 2, 3. And let's hear her 1 month following the botulinum toxin injection. 1 to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So we can still hear a slight breathiness in the voice. Almost for 7 days to 2 weeks following the injection, the voice gets pretty breathy. And dose titration is all about getting an optimal length of time with a good voice and decreasing the breathy period immediately after the injection to as little as possible. So the injection of botulinum toxin has a lot of advantages because you're not giving anesthesia, no admission to the patient. It hardly takes 10 minutes to do the procedure. It's acceptable to the patients. They have a good voice. But it's temporary, which can be taken as an advantage also in certain conditions. But because it's temporary, the patient has to come back every 6 months. And there are certain contraindications like pregnancy, aminoglycosides, myasthenia gravis. The side effects, which we explain every patient, is you're going to have a breathy dysphonia for about 1 week to even 6 weeks. And if the dysphonia is very breathy, it means basically there's a very large glottic chink, a very large phonatory gap, so then there would be possible aspiration to water or water-like liquids for a couple of days. The procedure per se is we prefer the sitting position with the neck extended so that the larynx becomes more superficial and the cricothyroid space will increase. So we have the patient sitting on a chair with a little bit of a shoulder pillow rest with hyperextension of the neck. We perform it, of course, in the Department of Neurophysiology. And what one has to identify is the thyroid notch, the lower border of the thyroid, the upper border of the cricoid, and the lower border of the cricoid. So in the first few cases, one can even mark these out with a pen to be certain. And then, of course, we have the surface and the reference electrode on the mandible or on the neck. And as I mentioned, we're using the monopole electrode. So what we already have sort of filled in the tuberculin syringes is the botulinum toxin, and typically we give 2.5 mouse units in both the thyroarytenoid muscles in a patient of adductor spasmodic dysphonia, and we use a 50 mouse unit vial. And for abductor spasmodic, we start with 3.75 mouse units, and we do it unilaterally because we don't want to take the chance of stridor in the patient. So we've kept the needles charged, and we introduce the needle through the cricothyroid membrane. Typically in a male, the needle will be bent to 30 degrees, in a female 15 degrees, about half millimeter from the midline and 30 degrees upward. The needle is bent upward and pointed laterally, also 30 degrees for male patients. So the idea is to use the cricothyroid membrane as an easy entry point to introduce the needle into the thyroarytenoid muscle. I'm going to show a small recording of the procedure.
Which is over here. This is the midline over here. We go about 2 millimeters from the midline in the cricothyroid membrane. We'll put the EMG machine on now. That is the sound of the machine. Just relax. Just one small breath. I'm entering the cricothyroid membrane. Say E. Yes. Say E loudly. Very good. I'm coming out now. You can put the audio.
So this is a recording of laryngeal EMG in a thyroarytenoid muscle. So that's a full interference pattern we look for. And what we're looking for in paralysis patients is fibrillation potentials, which may suggest active denervation, or multiple small polyphasic units, which suggest ongoing renervation and a better prognosis. So this is an EMG of a fibrillation potential in vocal cord paralysis. And let's come finally to bizarre. And we've seen this happen 2 to 3 times in our clinic. So basically what I'm going to show you is when we do the laryngeal EMG, when the patient phonates, on 2 to 3 occasions, we've had that sound amplified through the machine. And it really sounds bizarre with the patient saying E. And obviously the frequency must be matching the EMG machine because the entire audio sort of reverberates through the machine. Better, much better. आता मी सुई घालणार. Relax. Relax. What happened?
Yeah, it's on. Ready?
Yeah, I'm in.
Yeah.
आता ही म्हणा. एक काय नको म्हणा ना. Relax. दिला सोडा. ही म्हणा. So I'll show you the same thing with the EMG recording and the audio. So that's probably the only bizarre thing I can think of which has been happening with our EMG occasionally. We did do a research in the voice clinic to find out what the dose titration is like in our Indian population. And we published this study of ours. Basically, it showed that the units which we use in India are a little higher than the international units. So we are using about, on an average, this is overall the cases done over 7-year period, 4.2 units bilaterally and 4.6 unit unilaterally for the case of abductor spasmodic dysphonia. And the other thing we've been doing of late since the last 3 or 4 months with Dr. Kushnuma Mansukani is a quantification of the EMG activity of the thyroarytenoid muscles in patients with adaptive spasmodic dysphonia. So we've been using root mean square to check the amplitude, and we're trying to find out the amplitude of both the thyroarytenoid muscles in the same patient, whether it's an asymmetric sort of spasm which is taking place, and whether it is sequentially the same every time the patient comes to us over 6 months. It's a very early study with just 8 patients as of now, because then COVID took place, and of course everything else has taken a back burner. So of course, when we check the right and left thyroarytenoid muscles in rest and phonation, there is a difference with increased root mean square on phonation. That's not surprising. But what we've been trying to check is the right and left side of the same patient in the thyroarytenoid muscle. And we found an asymmetry in all the patients. In 5 patients, I think the right side had a higher root mean square in these 8 patients, but there's an asymmetry seen between the right and left side in all patients. And this is interesting because we're wondering whether this is going to be a finding which remains consistent every time the patient comes to us, in which case then we can think of titrating the doses so that the muscle which is in increased spasm gets more of a dose and the other vocal fold gets less of a dose, to see whether that helps in optimizing the vocal outcome measures. And performing a review of literature shows lots of studies have been performed on laryngeal EMG, but we did not come across any study where a root mean square was used in laryngeal EMG. So when we have enough data, we hope to publish it. Finally, a Bombay Hospital Voice and Swallowing Center with the Bombay Hospital EMG department is our Bombay Hospital Voice Clinic. And I thank you once again for giving me this opportunity. Thank you.